Hello and welcome back to RootCanal360. Today this is an interesting case. First and foremost, I apologize for the mirror. I didn't clean it off and I was in a hurry to get started. And this is a 86-year-old male, a veteran, and he came in with tooth number 8, previously treated with a really poorly placed post. The tooth is foreshortened. I'm not sure if it was due to trauma when he was younger, but the root canal was done. Short of apex, and it has a nice blunted root tip. We're going to be going through a porcelain crown. We're going to be using the diamond burr that I love and use consistently in every case. We're going to cut through that porcelain and then we're going to remove that post. You'll notice I've cleaned the mirror. I apologize for any sort of water remnant that was left after sterilization. Currently we're going through that porcelain crown. We're going to cut the smallest access possible. Again, I'm not a huge fan of ninja accesses. I don't think those are appropriate. Nor am I a fan of blowing open the access. You're going to see in a case coming up that I actually, on an anterior tooth, had to open up the access really wide. They did a access restoration that was really high, and they left a lot of unsupported enamel on the lingual aspect, and so I had to remove that. And it makes the access look terrible, but in this case we're able to keep that access as small as possible. As I go through this crown, I want to make sure that I do a very careful job of not fracturing the porcelain. So you're going to be doing brush strokes with that porcelain, short, steady strokes. You don't want to remove too much porcelain. You don't want the access to be too big, compromising the overall integrity. You can start to see that shine down in the base. That's the post. I'm removing the coronal portion of the post with my cross-cut fissured burr. We're going to remove that post down to about the CEJ. When I get down to the CEJ, I'm going to then use my ultrasonic to remove it. We're just going to slowly remove this. You know, the wonderful thing about that cross-cut fissure burr is even if I hit the porcelain, it hasn't in my case fractured any of the porcelain off. If I put too much pressure on, yes, it will fracture the porcelain, but if I do a nice, slow, steady, light pressure, it ends up being a wonderful burr to even enlarge porcelain crown accesses. So we're going to remove all of the post that's in the clinical crown. Again, we want to take it down to about the CEJ. At that point, I'm going to use my piezoelectric ultrasonic tip. There we go. Again, the piezoelectric ultrasonic tip is different than one that's used by a lot of hygienists. So hygienists have a ultrasonic tip that vibrates in an elliptical form. This is a linear vibration. It's going to be really exact. I'm going to go along the edges of that post, and we're going to just break up the cement that holds that post in place. Now you're going to notice that when we get this post out, it's a short post. I would do the same thing in this situation. If it was a really well placed post, I just go along the edges of the post and slowly vibrate it out. Here we go. We're going to get that to pop out. Now the reason I don't have my ultrasonic unit with constant spray is I actually like it when the assistant can spray and then wait a minute and then spray. It allows it an opportunity for me to see what's going on, and then at the same time that burst of water that they put on there, it kind of cleans up everything that's going on. So I prefer the on-off with the assistant spraying the water. You'll notice that we just got that post out. Now what I'm going to use is the ultrasonic again to remove the coronal aspect of the gutta-percha. I am not a big fan of orifice openers. Orifice openers are really stiff. They're perfectly round. When I get in there and clean out the coronal 1/3 of a canal, I prefer to use my ultrasonic. The reason I do is I can get it to shape to the anatomical form of that canal. I can get into little grooves. I can clean it really well anatomically without just creating a round hole. So in this situation, I'm going to remove a lot of that gutta-percha that's in the coronal 1/3 with the ultrasonic. Once I get a lot of that gutta-percha out of there, then I'm going to switch to my files. Now remember I said that this tooth was short. Clinically, it doesn't look short, but the root tip is about 3 millimeters shorter than the overall length of tooth number 9. So in this case, I'm going to flood the compartment with sodium hypochlorite. I'm going to use my rotary instruments to initiate the removal of the gutta-percha. I'm going to get to a point where not much of that gutta-percha is coming out, and I'm going to switch to a Hedstrom file. Now, a lot of studies show that rotary files are superior to Hedstrom files in removing the gutta-percha, especially with some chloroform. However, this tooth has a few things that go against it. One, the apex has a funky anatomy. It's not your typical apex exit, and so I'm not exactly sure what that's looking like. In the CBCT, it looked a little moth-eaten, almost like there was some sort of external resorption going on. And so I'm going to choose at one point, after removing some of the gutta-percha with the rotary files, I'm going to choose to use the Hedstrom file because of the tactile ability that I have. And I don't really have a true working length yet. The CBCT is great at giving me a preliminary working length, but when you've got kind of a moth-eaten apex at this situation, you never know where the exit truly is. So I really want some good tactile sense. In fact, when I use my Hedstrom file, I'm going to attach the apex locator because I don't really want to perforate the apex too much and cause any sort of apical trauma. I don't want to be an apical barbarian. So I've got that Hedstrom file. Again, the Hedstrom file is different than the K file. A K file is usually a triangle or a square that's twisted. It's great. It's got pretty much a neutral rake angle, which means it doesn't cut great. While the Hedstrom file, it's different in the fact that it's milled and it has a positive rake angle, which means it cuts efficiently. Mostly it cuts efficiently in an up and down motion, but in this situation I'm going to try and bind the gutta-percha, and then I'm going to pull it up. And you're going to see at one point I'm able to pull out the remainder of the gutta-percha, and you'll see a nice blunt end. And you're also going to see some of the dark staining, which is probably a little bit of bacteria and other contaminants. Here we go. I was able to pull that gutta-percha out of there, and I'm going to slowly just manipulate that out of the access so we can take a quick peek at that, and we can see how dirty that gutta-percha is. So there it is. So now we've got all the gutta-percha out. Now we're going to go to town and clean that canal. Now, I've got to get a working length. So with my Hedstrom, I've noticed that the gutta-percha was actually about 2 millimeters short of apex, that the true apical exit was 2 millimeters beyond their gutta-percha placement. So at this point I'm going to flood the compartment with sodium hypochlorite, and then I'm going to use my rotary instrumentation to achieve full length at an apical size that is appropriate for that tooth. Now, how do you determine the apical size? There are a lot of different opinions about this. I don't like blowing open the apex. There are some people that have far larger apical tip size than I do. There are also those that have far smaller. I'm kind of probably right in the middle. I don't want it too big and I don't want it too small. The Goldilocks philosophy, I guess, is what you might call it. So in this situation, I usually go to what feels like a somewhat bind. I don't want a nice tight bind. I don't want it to feel like I'm cracking the apex open, but I also don't want to just slide through like I'm getting no resistance. So it's one of those non-answers to how big should you go. Again, I usually will go to about the second file of resistance. So I'll get resistance with a file, and then I'll go one size bigger. And that's usually how I manage the apex. Some people might consider that, again, an apical barbarian. But In this situation, I'm going to clean out that apex. I'm going to flood it with lots of sodium hypochlorite, rotary instrumentation. And I believe at this situation we ended up going up to size 60, if I remember right. Now you're going to notice in this case, I'm actually not going to obturate with gutta-percha. I'm going to obturate the apex with a root repair material, which is bioceramic paste putty that is going to be placed in the apex. So I'm going to place the sealer down on the apex, and then I'm going to place the bioceramic root repair material from Brasseler, and I'm going to obturate that apex with that root repair material. And the reason is, again, I don't have a beautiful shaped tapered root. I have a blunt moth-eaten apex, and so I want to fill in as much of that as possible with the bioceramic material, whether it be in the sealer form or in the putty form. I want that to be doing most of my obturation, not the gutta-percha. So once I get this all cleaned and shaped just the way I want, I'm going to verify my length as well. I'm going to use a larger file. Now you're going to notice I'm using the XP finishing file from Brasseler as well. There's a few studies out there that show it's superior to passive ultrasonic irrigation. There's some studies that show it's not. I'm still a big fan of it. I find that when I use it, I get a lot of debris out. I was going to consider using my laser in this situation, but I decided because of the apex inconsistencies, I was afraid of maybe shooting out some sort of sodium hypochlorite or any other debris out the apex, because I know sometimes the energy can be consistently amazing with the laser. However, in this situation, I chose to stick with the XP finishing file to help agitate that sodium hypochlorite. I definitely would not use a gentle wave in this situation with the apex the way it is. I'm going to try the gutta-percha in, and I'm going to find that I just don't like the way it feels. It feels sloppy in there. I was going to go bigger and maybe trim it down, but again, I didn't want to do that. I want a nice tight anatomical feel. Some people will put chloroform on the tip. The problem with putting chloroform on the tip is that chloroform will cause it to shrink over time. So I'm not a huge fan of doing that. So in this case, I decided to not obturate with gutta-percha. As I've already talked about, I'm going to place the root repair material, the bioceramic putty, down at the apex, and you're going to watch the way I do that. Now at this point, I'm just going to irrigate with the classic passive irrigation technique. I'm able to get that nice and clean, nice and dry with my paper points. I've really sped this up, so I don't want to bore you with too much irrigation, but it was a long time, and I really sped that up. We're going to get this nice and dry, and I'm going to use those not the same ones here, but I'm going to use the paper points to help place the root repair material. I'm verifying my length here. In a case like this, I want to make sure that I do not go long. I would rather go a little short than long. There's no need to cause any sort of inflammation by pushing a lot of foreign material past the apex. So I'm going to place a tiny amount of sealer at that apex, and then I'm going to place that root repair material in there. And I find that it can be a little sticky, and so I'm going to pat it down just gently with the glick in this situation, and then I'm going to take my paper points. I've measured them out. I've got them pinched down to a length that I know I should be going to. I'm going to push it down. I'm going to get a little bit of resistance, and then I'm going to actually place a little bit more root repair material down there. The putty is kind of a pain to work with. You have to be gentle. This can be really irritating if you get stuck to the metal tip and it keeps pulling itself out. I notice if I keep my condensation short, brief, and lots of small little pecks at it, it doesn't stick to the instrument as much. I also find that these paper points do an amazing job of packing that down into that. You'll notice I actually turn the paper point upside down in this situation as I'm working my way up the canal towards the clinical crown. The orifice getting bigger, I want to make sure I have a bigger tip size. So at this point now I'm going to backfill with gutta-percha, and I'm going to condense that so I've got a nice tight seal on top of it. This would also be nerve-wracking because sometimes you can push really hard and you'll push that paste or putty out the apex, and that actually is very irritating. So if you ever have that happen, join the ranks. I think anybody who's had to operate this way has done that, and it's very irritating. Once we get this nicely packed and in place, we're going to clean it, the orifice, with the ultrasonics, and we're going to place a restoration. I appreciate you watching. I hope you enjoyed the video. If there's anything that you have questions about, please feel free to post a comment, and hopefully I'll be able to respond. If you think there's something I could do better, I'm always willing to learn. I love endodontics. I love doing root canals, and I love learning. So if you have anything to add, please do. I'd love to hear from you. As I go through this process, you're going to see I'm going to etch, I'm going to treat the porcelain, and then I'm going to bond, and I'm going to place the material. We're going to speed this up consistently. Again, I appreciate those that stick around and watch, and hopefully there will be a few more coming your way. Place the bond, place some more bond, air dry, cure, and place the composite. I like to blow a little air again on my composites to push them down. And never water, make sure it's dry. Clean up the composite as much as I can. Set it. This is at 3 times the speed, so I wish I could do an adequate root canal in 18 minutes like this video shows, but it's definitely longer. Speeding up in certain areas like the irrigation and the placement of the composite and other aspects as well. Once we get this removed, we're going to remove all the excess caulking, and we're done. Thank you so much.